Hello, my dear friends. Today we will continue our webinars. It's clinical part of pharmacovigilance. Today we will talk about predisposing factors of adverse reactions. I'm thankful for question which I have received from my colleagues, and today we will make two records of my lectures, and I hope I will take into account all your needs which I receive in LinkedIn and Facebook, and thank you very much for your questions. Let me introduce myself, and I would like to introduce myself. My name is Galina Cordero. I am qualified person of pharmacovigilance, head of pharmacovigilance department, clinical expert, GVP.Pharmac, Ukraine. Today we will continue our webinars, and we will talk about factors predisposing to adverse reaction. Why it's very important? Because every medical doctor, pharmacist, pharmaceutical industry specialist, as pharmacovigilance physicians, pharmacovigilance officer, and medical advisors, and everybody should understand that adverse reaction has factors predisposing. When we will talk about classification of factors, we can classificate as drug-related factors, and we should take into account dose, dosage form and delivery system, interaction between drugs, and polypharmacy. Patient-related factors include age, geriatrics, age, pediatrics, and concurrent disease, because every patient can has not just one disease but several one. And what we should pay attention, it's on hepatic disease, renal disease, other diseases, genetic factors, gender, and nutrition, because we can say, for example, Japanese population, and for example black people population, or for example Mexicans or Puerto Ricans can have different adverse reaction. It can be connected and related with genetics factors, and we will talk about it later, because as we see that in different population drugs can act a little bit different, and it can be reflect difference in efficacy and difference in adverse reaction too. Drug dose and frequency. Drug dosing affects the development of adverse reactions in many ways. It can be some drugs need to be given in the morning and other in the evening, some at bedtime. Plus, I would like to pay attention that some drugs you should take before meal. Some drugs you should take with meal, and some drugs you should take after meal. And you, as a medical doctor or pharmacist, should pay attention patients. And this information you can find in patient leaflet. It's for patient information, and SMPC. You can find this information for medical doctors. Taking biphosphonates at bedtime may lead to esophagitis. The antiplatelet effect of aspirin when taken in the evening is more potent than the morning dosing needs to be considered as a factor which might have some effect on the development of the adverse reaction. Polypharmacy. Polypharmacy is enough big problem because patient can have many diseases, and every specialist can treat just own disease. For example, gastroenterologist can treat ulcerative disease, for example, but patient can have ulcerative disease and rheumatic disease, and we can see that medical doctor should be very careful with administration and prescribing of drugs, because it can be different comorbidities have role on adverse reaction, plus and drug-drug interaction, and we will talk about in drug-drug interaction lectures, webinar, because all cases which we will discuss with you, it's real cases which happened in patients. Polypharmacy is a result on many conditions. Patients might suffer from more than one disease, especially among the elderly population and among the elderly patients. Patients might seek more than one prescriber at the same time for different diseases or acute or chronic condition. Adverse reaction may occur due to drug interaction, synergism, duplication, additive effect, discontinuation of therapy. It can be, for example, you can meet this adverse reaction in beta and renal blockators, discontinuation of therapy. Be very careful of it. Changing the dose to save money, skipping some medication, and physiological antagonism too. Drug-related factors: drug dose and frequency dose of medication, frequency of administration, and time of the day at which the drug is administered significantly affect the occurrence of adverse reaction. Administering underdose or overdose of medication, increasing or decreasing frequency of administration, changing the appropriate time of the day to administer the medication can cause patient harmful drug effects. Aspirin, when taken at night, yield better antiplatelet action. Diuretics, like for example bendrafluazide, should not be taken at night to prevent sleep disturbance. Polypharmacy. It involves prescription of too many medications at the same time for a single patient that clinically required. Single patient, especially the elderly, may visit different prescribers for his various disease conditions, which may result to polypharmacy. Polypharmacy may cause adverse reaction due to the drug, additive effect, again, synergism, duplication, drug interaction, discontinuation of treatment, and physiological antagonism. Why I repeat it? Because, as I said before, it's now enough big problem among medical doctors who prescribe medical medicines, medical drugs. Polypharmacy. One important reason for the development of adverse reaction from polypharmacy is the inability of some patients, especially the elderly, to keep track for using their medication regardless of how well the medication may work or if given alone. If the patients are not strict enough to take the medication as prescribed, when they will separate from treatment and not take the medication properly. Drug interaction. Drug interaction play a very important role in the development of polypharmacy. It can be defined modulation of the pharmacological activity of one drug by the prior of the concomitant administration of another drug. Interaction which occurs when the effects of one drug are changed by the presence of another drug. Drug interactions are multifaceted and include drug dose, serum drug level, route of administration, drug metabolism, duration of therapy, and patient factors such as age, gender, weight, and genetic predisposition. The frequency and prevalence of interaction is dependent upon the number of concomitant drugs and the complexity of the regimens. The prevalence is also dependent upon other variables such as patient adherence, hydration, and nutritional status, degree of renal or hepatic impairment, smoking and alcohol use, genetic and drug dosing. Drug combination may sometimes cause synergistic toxicity, which is greater than the sum of the risk of toxicity of either agent used alone. Patients concurrently receiving corticosteroids, as example, and steroids, anti-inflammation drugs, had a risk of peptic ulcer disease that was 15 times greater than that one non-user of either drug. The concurrent use of antidepressants, hypnotic, antiepileptic, and antihistamines may lead to more drowsiness. Both vancomycin and narcotics induce dose-dependent skin reaction and synergize to cause adverse reaction. Prescribing cascade occurs when patients take medication and suffer from some adverse drug reaction that are misdiagnosed by the physician as symptom of disease requiring more medication. For example, antihypertensive, sedative, opioids, nesteroids, drugs, antiepileptics, antibiotics, and herbal medication are some of the mostly frequently prescribed drugs. The cascade includes the use of prochlorperazine to prevent drug-induced dizziness, antihypertensives to treat nesteroid drug-induced hypertension, and levodopa to manage metoclopramide-induced movement disorder. Prochlorperazine, for instance, may cause postural hypotension, which may exacerbate any hypotensive effect of antihypertensive drugs. This cascade might be the cause of hip fracture following the use of prochlorperazine. ICE is inducing COH. It's antihypertensive drug blockator and it can be blockade bradykinin. Maybe induced COH may be misinterpreted as a chest infection and given antibiotics because, as you see, many patients whom prescribed ACE drugs, antihypertensive drugs. These symptoms as a cough can be medical doctor can make the diagnosis and thinking that it can be, for example, chronic bronchitis as a chest infection and give antibiotics and cough suppressant. And it will not be treated as adverse reaction at least, and can be cause of other adverse reaction too in this category of patients. TIZ diuretics may cause hyperuricemia, which leads to prescribing colchicines, which in turn may cause diarrhea. Erythromycin may cause arrhythmia, and we know these cases, and be misinterpreted as a disease and given antiarrhythmics. Antiepileptics may cause a rash, which leads to corticosteroid use. Using therapeutic equivalents to treat the same illness is considered one of the causes of adverse reactions. For example, two analgesics, antihistamine with other sedative drugs, or two antihypertensives are some examples of using two medications which exhibit the same actions. Lack of coordination between physicians, pharmacists, and patients can lead to redundancy using the same medication under different brand names. This will increase the risk of adverse reaction too. Polypharmacy. If use of non-prescription drugs, OTC, and traditional medicine significantly enhances the occurrence of adverse reaction. It is reported that patients above 65 years use an average of 2 to 6 prescribing drugs and 1 to 3.4 non-prescribed drugs. In another study, it was also stated the patient treated with nonsteroid anti-inflammation drugs and corticosteroids at the same time had 50 times risk of developing peptic ulcerative disease that patient not taking either of two drugs. Prescription cascade may arise when physician could not diagnose adverse reaction regarding it is a symptom of disease that warranted an additional medication leading to more adverse reaction. Hyperuricemia caused by thiazide diuretics that lead to prescription of colchicine with tone may cause diarrhea. It is clinically wrong to use two medicines of same class and efficacy to treat one disease condition because it will promote occurrence of adverse reaction. Use of two therapeutically equivalent, for example, nonsteroids or antihistamines. Multiply drug therapy more prone to develop of adverse reaction, easy to interaction or by synergetic effect. There are some strategies we will talk about in separate lecture concerning on medication error. Today we will talk about strategies to reduce medication errors which can be predisposing factors of appearance of adverse reaction too, because the Committee of Quality of Health, for example, care in United States, has suggested the following measures in order to tackle problems arising from medication errors. It standardize prescription writing and prescribing rules, implement physician order entry, use pharmaceutical software, implement unit dosing, include pharmacy during word round, and this role of pharmacists now is rising too in administration of drug, because when we talk about OTC group, and this group can every patient can go to pharmacy and pharmacists can give advice, for example, what kind of drugs better from OTC group 2, because it can be situations in pharmacy this drug is absent but there is some another drug of this group, and it's why role of pharmacist now is rising. Limit varieties of same medicine, make relevant patient information available at the point of patient care, educate patient more about his treatment and success of it. It's a interaction between a dialogue between medical doctors and pharmacists and patients. Patient-related factors. Age has significant effect on development of adverse reaction, especially the extreme ages, that is pediatric and geriatric patients. Pediatric and geriatric categories of patients are not usually studied extensively during clinical trials. Geriatric patients with multiple disease conditions decreased drug elimination and previous history of allergy are more prone to adverse reaction. However, pediatric patients have low capacity to metabolize drugs, hence more prone to adverse reaction. Older patients have many health problems and thus take several prescription and over-the-counter drugs. As people get older, the liver loses the ability to metabolize drugs. Older people are more than twice as susceptible to adverse reaction as the younger people. The amount of water in the body decreases and the amount of fat tissue relative to water increases in older patients. In older people, drugs that dissolve in water reach higher concentration because there is less water to dilute them, and drugs that dissolve in fat accumulate more because there is relatively more fat tissue to store them. The kidneys are less able to excrete drugs into the urine, and the liver is less able to metabolize many drugs. Neonates have immature renal tubular function when they are below the age of 8 weeks. Avoiding digoxin, aminoglycosides, ACE inhibitors, and steroids is a must. Physiologic hypoalbuminemia in neonates affects drug dosing. Caution is recommended when dealing with higher proteins binding drugs such as nesteroid and anti-inflammation drugs. Neonates have low body fat. They might be affected by fat-soluble drugs. Increased anesthetics effect due to immature blood-brain barrier less 8 weeks of age. Prediposing to hypertension due to poor cardiac compliance and immature baroreceptors. Use of drug in children generally pose a lot of challenges in health care delivery. Prescribing, dispensing, and administration should be done with care. Pediatric medication is calculated based on weight in most of the prescription and involves a lot of calculations that are liable to mistakes. Errors due to pediatric dosage calculation have led to adverse reaction in many instances than in adults due to their fragile nature. Elderly patients have low amount of water in their body, leading to the increase in fatty tissue relative to water ratio. This causes water-soluble drugs to reach higher concentration due to the presence of less water to dissolve them. It also causes decrease in the concentration of fat-soluble drugs to the presence of higher fat to dissolve them. Furthermore, ability to excrete drugs via kidney and rate of liver metabolism also decreased in elderly patients too. Gender. Men differ from women in jet motility, also have higher body weight, internal organ size, and glomerular filtration, but lesser body fat. These factors affect both the drug's pharmacokinetics and pharmacodynamics. Studies have shown the female patients have more active cytochrome P3A4 hepatic enzymes than male patients, indicating the difference in rate of drug metabolism with the enzyme. Hospital studies indicated that women aged 17-44 years visit physician and stays in hospital at twice the rate than men. The anatomical and physiological difference are body weight, body composition, gastrointestinal tract factors, liver metabolism, and renal function. Women in comparison and men have lower body weight and organ size, more body fat, different gastric motility, and lower glomerular filtration rate. This difference can affect the way the body deals with drugs by altering the pharmacokinetics and pharmacodynamics of the drugs, including drug absorption, distribution, metabolism, and elimination. Hepatic enzyme cytochrome 3A4 is more active in females than males, which lead to different effects on drug metabolism. Women are more prone than men to develop torsade depoins, ventricular tachycardia during the administration of drug, for example as erythromycin, that prolong cardiac repolarization. Women restrict their activity because of acute and chronic health problems approximately 25% more days per year than do men, spending approximately 40% more days in bed each year than men. Angiotensin-converting enzyme inhibitors and COAH. Females had a higher incidence of COAH compared to men. When we see percentage is 37.09% and 15.5%. In Chinese population, the metabolism of midazolam in women is more than in men due to the activity of cytochrome 3A4. Chlorpromazine and fluoxetine seem to be more effective in women than in men for the same dosage in plasma concentration. Pregnancy. During pregnancy, several physiological changes occur which may affect drug pharmacokinetics as well as pharmacodynamics. These include cardiovascular changes. Increase in cardiac output 32% due to the increase in heart rate 10-15 BPM, and increase in stroke volume, increase in blood volume. Increase in renal drug excretion due to the increase in renal blood flow 30%, increase in DFR 50%, and decrease in serum protein. JIT motility, acidity, and tone increase during pregnancy, which leads to changes in drug absorption, excretion, and metabolism. During pregnancy, adverse reaction may affect only the mother, the fetus, or both. Fetal development. Fetus is sensitive to drugs in maternal circulation because of its fragile nature. Low metabolism and excretion capacity may cause teratogenicity. Teratogenicity and other adverse reactions usually occur when drug is taken at the first trimester during fetal organ formation. Effect of neonate or infants usually manifest when the drug is taken at the second or third trimester, leading to growth retardation, respiratory depression, infection, or hemorrhage. Adverse effects depend on the type and amount of drug taken, duration, and stage fetal growth. Renal function. Renal function, kidney disease alters rate of drug clearance and metabolism, leading to drug toxicity and low therapeutic effect, which can be diagnosed by level of creatinine clearance. Decreasing in drug clearance in patients with kidney failures is a result of certain changes that occur in drug transport system and metabolic enzymes. Renal insufficiency also affects non-renal drugs clearance by introducing another disease of infection that leads to the possibility of drugs. Allergy. Allergy drug-independent cross-reactive antigens can trigger sensitization which can become drug allergy. Cross-sensitivity usually occurs among drugs of same class or of similar structure. After first drug exposure by the patient, second exposure may cause T-cell and antibodies to enter elicitation phase, similar to the type 1 to 4 immune reactions. Drug allergics commonly encountered by patients are type 1 or type 4 reactions, while type 2 and 3 are very rare. The clinical manifestation of type 3 reaction includes serum sickness, for example penicillins, lupus erythematosus, for example quinine, and vasculitis, minocycline. It's believed that sulfonamides and beta-lactams antibiotics are common cause of drug allergy too. Disease-related factors. Disease-related factors presence of multiple disease conditions at this time predisposes patient to drug-disease interaction, which may eventually lead to adverse reaction. For example, increase in frequency of idiosyncratic toxicity with anti-infective drugs such as trimethoprim, sulfamethoxazole. Drugs that is useful in treatment of one disease may be harmful in others. Using steroids to treat pain may exacerbate peptic ulcer. Also, condition of patient with asthma may worsen if he is treated with propranolol for angina or hypertension. Patients with chronic disease like diabetes, higher or low blood pressure, ulcer, glaucoma, and large prostate, poor bladder control should be monitored carefully because such categories of patients are more prone to drug-disease interaction and adverse reaction. Drug like prednisolone can cause fluid retention and may worsen congestive heart failure. However, drug-disease interaction may have an insidious onset, thus monitoring on patients becomes necessary. Research related to AIDS increases the possibilities of developing adverse reactions like Stephen-Jones syndrome and toxic epidermal necrosis. Disease-related factors, presence of multiple disease conditions, aside time preservation to drug interaction which may eventually lead to adverse reactions. You should pay attention. When we are talking about disease states, it can be metabolism, phase 1 or phase 2 may be impaired with hepatic disease. It can be caused cirrhosis, hepatic carcinoma, renal insufficiency, acute or chronic renal failure, decreased glomerular filtration rate, GFR. Drugs level may become toxic if too high, so dosing modification may be indicated. Social factors, race and ethnicity. Race and ethnicity, it's predisposing factors, and you should take into account too when you administer drugs. Ethnic background is believed to be controlled by genetic factors which are responsible for genetic polymorphism and individual difference in enzyme ability to metabolize drugs, differences in drug receptors and transporters. Occurrence of adverse reaction differs from one population of patients to another due to genetic difference. In a cohort study to investigate factors that predispose patients to adverse reaction by angiotensin-converted enzyme (ACE inhibitors) using 2,025 people, where 19% dropped out due to adverse reaction, it was found that African Americans are more susceptible to ICA-related angioedema than other ethnic groups. And I pay attention on this fact that angioedema can appear as an adverse reaction in African American as ethnic groups. Research has shown that black people had higher risk of intracranial hemorrhage and also had 3.0 relative risk of angioedema compared with non-black people. Patients from East Asia have 3 times more risk of developing cough with IC inhibitor than white patient Caucasians. Patients suffering from Parkinson's disease who have ODP glucuron acetyltransferase 1A9 genotype are more susceptible to adverse reaction when treated with catechol or methyltransferase inhibitors. Current research indicated that patients that develop adverse reaction have higher cytochrome 1A2 low allele combination and lower cytochrome 1A2 mRNA than patients that do not develop drugs. Social factors include alcohol too. Alcohol affects drug metabolism and promote development of drugs. Alcohol causes hepatitis and liver cirrhosis that significantly affects the rate of drugs metabolism. Liver disease is proved to increase the toxicity, for example, of beta blockers. Chronic alcohol intake activates enzymes which accelerate drugs metabolism and causes toxicity. Taking alcohol with nonsteroid anti-inflammation drugs by patients having peptic ulcer or gastritis may cause internal hemorrhage. Concurrent ingestion of alcohol with some drugs has led to many adverse reactions like nausea, vomiting, headache, drowsiness, faintness, and hypertension. Smoking is identified as one of the risk factors for peptic ulcer, cardiovascular disease, and cancer. Smoking induces liver cytochrome P450 enzymes cytochrome 1A1, 1A2, and possibly A2 leading to the increase in metabolism of drugs that are substrate to this group of enzymes and decrease their pharmacological action. Studies revealed that cigarette smoking decreases the action of beta blockers on blood pressure. Smoking also interacts with drugs like theophylline, thiotaxine, insulin, oral contraceptives, and H2 blockers. Clinical investigations proves that one average insulin-dependent diabetic smoker needs 15-20 more insulin than non-smokers and up to 30% more for heavy smokers. Pregnancy. Use of sulfonylamides can lead to jaundice and brain damage in the fetus. Warfarin use for anticoagulation can lead to birth defects and decrease in risk of bleeding problems in newborns and mother. Lithium for bipolar disorder can lead to defects on the heart, lethargy, reduces muscle tone, and underactivity of the thyroid gland. Breastfeeding. Similar concern as far as the children with underdeveloping capability to metabolize or excrete xenobiotics. Many drugs can be passed from mother to infant via breast milk. It can be amantadine, it can be cyclophosphamide, and carisoprodol. Dear colleagues, thank you for your attention. We today discussed predisposing risk factors, and I will be very thankful for your question and we can share and we will discuss clinical situation. Today I will record another one lectures. It will be daily drug-induced liver injury, and I will be thankful if you will like my lectures, ask questions. You can leave it on the YouTube channel, you can leave in LinkedIn and Facebook, and plus please subscribe on my channel, and see you later on my another lectures. And I will be thankful if you will discuss which topic we can make, and I will present it lectures as live webinars where we can discuss live cases. For example, after lecture drug-induced liver injury, I am planning another one lecture with discussing real cases drug-induced liver injury. Then we can make round table where we can discuss it and share our point of view, our experience, how you manage the situation. Because when you see in literature so many cases, and now medical doctors, I think, will be very thankful for this information, because they have many patients, they have a big loading every day, and this additional information, clinical significant, will be very helpful in their practical daily practical activity. Thank you very much, my colleagues. See you later in my future lectures and webinars.